All right, so we'll start our discussion of valvular heart disease today. So starting with this radiograph, so from the lateral view, what is this valve? That is a tricuspid valve, right. So the tricuspid valve is the most inferior valve. Okay. What is this guy? That's the aortic valve, and then what is this guy? Mitral valve. So where would the pulmonic valve be? More superior and anterior. So the pulmonic valve is the most superior valve. The tricuspid valve is the most inferior valve. And then notice the proximity of the aortic valve and the mitral valve because of fibrous continuity, right. And then we know that the tricuspid and the pulmonic valves are separated because of the infundibulum, right. So that's the difference between the left ventricle and the right ventricle. Okay. So we talked about already where the pulmonic valve would be. On the frontal view, it's a little bit harder to separate the aortic valve from the mitral valve, but again, the aortic valve is usually going to be superior to the mitral valve in the frontal view. All right, so when we look at this chest radiograph, before we get to what the valve problem might be, what are the abnormalities here on the chest radiograph? So what's abnormal on the chest radiograph? So
aorta is slightly tortuous.
okay, so especially what part of the aorta? So you see the ascending aorta here, right? So it's a little bit curved. Do you see it on the lateral view? It's this guy right here. Right? So we have a dilated ascending aorta. Okay. The heart size, normal or abnormal? Normal, right. So the heart size is normal, dilated ascending aorta. And is there any other finding that really helps you here? Yeah, and where do you see that best? Yeah, so on the lateral view, right, we can see that there is some calcification here in the region of the aortic valve. So with aortic valve calcification and dilatation of the ascending aorta, what do we think this patient has? Yeah, it's aortic valvular stenosis, right. So tortuous ascending aorta, really dilated ascending aorta, aortic valvular calcification. So this is a patient with aortic valvular stenosis. And what kind of study is this?
Right blood MRI.
Is that an MR?
Oh.
What is it? Yeah, I mean, look at the bones, right?
Oh, whoops.
See the bones there. Okay. So that's a CT scan. It's a cardiac gated CT, right? And what does it show? Yeah, so we can see the aortic valve is not opening all the way. Does it show anything else about the aortic valve? Yeah, it looks like a bicuspid valve, and there's also extensive aortic valve calcification that doesn't surprise you. So in this case, this person has a bicuspid aortic valve with extensive calcification. Okay. So when you're looking at the aortic valve to tell the morphology, this is an MR. Okay, so when you're looking at the aortic valve to tell the morphology, it's when the aortic valve is open in systole that you can really tell the morphology of a bicuspid aortic valve, when it opens like a fish mouth, like you see there. When it's closed, you can't really tell if it's tricuspid or bicuspid morphology. So we have to look at the aortic valve when it's open to be able to tell if it's a bicuspid aortic valve. So here's a bicuspid aortic valve. What's illustrated on this side? Yeah, coarctation. So what's the relationship? Why am I showing you both of those things? What's the relationship between bicuspid aortic valve and coarctation?
People with coarctation of aortic valve, coarctation of the aorta, are more likely to have.
Yeah, that's right. So most patients with coarctation of the aorta, about 70% of patients with coarctation of the aorta will have a bicuspid aortic valve. So if you make a diagnosis of a coarctation, you need to very carefully look at the aortic valve. Most of these patients will have bicuspid aortic valve. Of course, it doesn't work the other way. Most patients with bicuspid valve are not going to have coarctation. So it works this way. If we make the diagnosis of coarctation, then you have to evaluate for bicuspid aortic valve. So there are, I've given you the different classifications of aortic valvular stenosis. So we'll talk about some of this. What's the most common cause of valvular aortic stenosis in the United States? Yeah, so it's atherosclerotic degeneration of a tricuspid aortic valve. And the second most common cause would be bicuspid aortic valve, right? So age-related degeneration of a what started out as a morphologically normal aortic valve, and the tricuspid aortic valve is the most common cause of aortic stenosis, and then that usually goes on to calcify, which we will see. And the second most common cause is bicuspid aortic valve. Rheumatic heart disease can also be a cause of aortic valvular stenosis, although most patients who have aortic valve stenosis from rheumatic heart disease also have involvement of the mitral valve, so the mitral valve gets involved first. In terms of the severity of stenosis, it does correlate with the valve area, and you have to measure that when the valve is open. So you don't have to memorize these numbers, but 1 centimeter square is a good number to know, because if the valve area is less than 1 centimeter squared, then you do have, you're going to run into some significant aortic valvular stenosis. And you're familiar with the symptoms of aortic stenosis and, of course, the complications of aortic stenosis, endocarditis, aortic insufficiency. Whenever the aortic valve is damaged, you not only can get stenosis, but you can also get aortic insufficiency. So for the younger patients, aged less than 65, the bicuspid aortic valve is going to be the most common cause of aortic valve stenosis. Bicuspid aortic valve is the most common congenital cardiac malformation, present in about 0.5 to 2% of the population. And then rheumatic heart disease is the second most common cause in that younger age group. For the older age group, and this is most of the cases that we will see with aortic valvular stenosis, it's going to be atherosclerotic degeneration of what started out as a normal aortic valve. So the normal aortic valve is tricuspid. When you have a bicuspid aortic valve morphologically, that can lead to abnormal flow through the aortic valve, turbulent flow, which then damages the valve and can lead to then fibrosis, calcifications. This is what the normal aortic valve should look like, of course, when it's open. Tricuspid aortic valve when it's open. And then here it is on cardiac gated CT. So there's a nice tricuspid aortic valve, and you can see what it looks like when it's wide open. 3 leaflets wide open there in systole. Okay. And then when you have here's a bicuspid valve, the leaflets will get thickened, and then here you can see the calcifications that can form on the leaflet on the X-ray, and that leads to damage of the leaflets and aortic valvular stenosis. Now, there are different types of bicuspid aortic valve. They're kind of illustrated here, okay? So first of all, what's different between these three different types of bicuspid aortic valve? What's different about this? So what do we call this? Yeah, that's a true bicuspid valve. It truly is morphologically bicuspid, right? These valves are bicuspid because of fusion of the raphe, okay? So what's different between this one and this one? So if you're trying to localize, and we've talked about this, the leaflets of the aortic valve, right? To localize them or to be able to name them anatomically, what's the landmark that you start with? The intratracheal septum, right? So you localize the intratracheal septum. The leaflet that's closest to the intratracheal septum is which one? Non-coronary, or the posterior leaflet, that's closest to the intratracheal septum. Which one would this be? Right, and this would be left. So which ones are fused here? The left and right are fused, right. Here we've labeled them for you here. So here, which ones are fused? Yeah, the non-coronary or the posterior and the right here are fused. Of these 3 different combinations, which one is the most common? B is the most common, right. So the pure bicuspid aortic valve, when we have symmetric cusps with no raphe, actually a small percentage, 70%. Fusion of the left and right coronary cusps, that's about 70% of bicuspid aortic valves. And then fusion of the right and the non-coronary cusp, which is what you see here, is about 28% of what we see with aortic valvular stenosis. This form is the one that is most closely associated with aortic coarctation. And fusion of the left and non-coronary cusp So the one that I didn't show you, that one is actually really rare. It's about 1%. Right? So those are the different morphologies of a bicuspid aortic valve. Okay? So here's a pure bicuspid valve. Let's see, you can tell the morphology there when it's open. Okay? Then here there's fusion of the right and the left cusp, and with extensive calcification. Now, there are going to be some times in adults and in older patients where they develop adhesions and they develop extensive calcification. And it might have started out as a morphologically tricuspid valve and then becomes functionally bicuspid. So there are going to be cases in older individuals where you're not going to be able to tell, was that a congenital bicuspid valve or has it just become functionally bicuspid because of adhesions that formed along the raphe? And those usually have extensive calcification. Okay. All right, bicuspid aortic valve is also associated with dilatation of the ascending aorta, even if they don't have aortic valvular stenosis. So if you have a young patient with a dilated ascending aorta, it is important to look at the aortic valve, because dilated ascending aorta is associated with bicuspid valve, even if they haven't developed aortic stenosis. And that also places the patient at increased risk for dissection. Right? So you need to remember that relationship also. All right, so here we have a 20-year-old man, and I'm telling you the patient has severe aortic stenosis. And the question is, what abnormality could account for this? First, what are some of the abnormalities that we notice here on the CT? What are things that are abnormal? What can we say is abnormal here? Anybody? Any findings here on this CAT scan? Is that a normal CT for a 20-year-old? Yeah, so first the aortic valve here is calcified. What do you think of the cardiac? Well, look at the lungs. What's wrong with the lungs? Well, what do you think these are? Yeah, there are bilateral pleural effusions. We have some dependent opacities there at the lung bases. The heart itself, besides the calcified aortic valve, what else is abnormal? Yeah, there's a big heart. What's big? What chambers are big? Especially what chamber? Right atrium is a little on the big side, but what chamber really strikes you as big here? Yeah, the left ventricle, right? So what else about the left ventricle? It's big and it's thickable, right? It's hypertrophy. Does that surprise you as somebody with severe aortic stenosis? No. And with the dilated left ventricle, the fact that he has bilateral effusions are going to make you think what? Yeah, so it's decompensated, right? So the patient's developed some failure here with bilateral effusions, big left ventricle. This is a 20-year-old, okay, who has severe aortic stenosis and calcification there of the aortic valve. What do we think is wrong with this person? So bicuspid aortic valve certainly can cause, right, aortic valve calcification and aortic valvular stenosis. This patient is still young, even for somebody to have a congenital bicuspid aortic valve. To have, well, rheumatic heart disease, again, that's an older age group, and those patients usually have involvement of the mitral valve.
What about like
Okay.
Williams syndrome?
So what?
Like Williams syndrome?
So Williams syndrome, the stenosis in Williams syndrome is where? Supravalvular. This patient's problem is where?
On the valve.
Is at the valve. Okay? So young patients who have aortic valvular stenosis, you have to think about, of course, morphologic abnormalities of the aortic valve itself. The most common morphologic abnormality is a bicuspid aortic valve. Certainly you have to consider that. Is there any other rarer morphologic abnormality of the aortic valve that can especially lead to severe aortic valvular stenosis? What is that? Yeah, unicuspid aortic valve, which is kind of rare. But a unicuspid aortic valve, right, where it's like one big cusp with a small little opening in it, right? That's a unicuspid aortic valve. These patients have severe aortic stenosis. This is diagnosed at a younger age, usually in childhood, okay? So young person with aortic valve stenosis, think about morphologic abnormalities of the aortic valve. This one is rare, unicuspid aortic valve, but that leads to severe aortic valvular stenosis, right? So there are different aortic valve morphologies that we can have. We talked about bicuspid valves, the tricuspid valve, the bicuspid valve, and then the unicuspid valve. This one has severe aortic stenosis. Okay? So what do we look for? Dilatation of the ascending aorta on the chest x-ray, calcification of the aortic valve. If we see calcification of the aortic valve on the plain film, it always means aortic valvular stenosis. Usually the left ventricle is normal in size until you get decompensation. Of course, there will be thickening of the myocardium, but you can't tell that on the plain film. On angiography, you might see thickened doming of the aortic valve. So aortic valve calcification, if we see it on the plain film, always means aortic valvular stenosis. Poststenotic dilatation, which on the plain film might cause this kind of what looks like tortuosity of the ascending aorta. Okay? And then on angiography, you can see that it's not opening all the way, but the thickened leaflets. That's some poststenotic dilatation of the aortic valve. So that's what we see with aortic valvular stenosis. So here's a cardiac gated CT. We can see the morphology of this valve is what? Tricuspid, yeah, it's a tricuspid aortic valve. There are some calcification. There is some mild stenosis. It's not quite opening all the way, but it's not severe. There's some mild aortic stenosis there. And then this one is more severe. So you can see as the aortic valve opens, the leaflets are thickened. There is calcification. It's not quite opening all the way, and we can measure how far it opens. That's called planimetry, and I've shown you that how those measurements can correlate with the degree of aortic valvular stenosis. So on CT, the way we grade or the way we can think about how severe is the stenosis is by looking at how much the aortic valve opens. So you would need a retrospectively gated CT scan. You would need images in systole to be able to look at the aortic valve when it's maximally open, right, to grade the severity of stenosis. And then here's a coronal view also showing you the aortic valve is thickened. You can see the left ventricle is also thickened. Calcifications of the aortic valve. And you can see it's quite not opening all the way. You can tell that even on this ascending aorta view of the aortic valve. Okay. Here's a bicuspid valve on CT. This one doesn't have much aortic stenosis. There isn't any really here, but the morphology is of a bicuspid valve. Okay. Pure bicuspid valve in that case. All right. So what kind of study are we looking at here? So this is an MR. What kind of view is this? Yeah, so it's a left ventricular outflow tract or a three-chamber view. This is also called a three-chamber view. So this chamber is left atrium, this guy, left ventricle, this guy over here, aorta, right? So ascending aorta. This one's kind of a four-chamber view, is close to a four-chamber view. So this guy is
left ventricle,
and this guy,
right ventricle,
this guy over here, left atrium. And then here's a view through the ascending aorta. Okay. So, do we see any flow disturbance? Yes, we do see flow disturbance. So where is it located?
That's the aortic valve. You see some tuning.
So is it at the aortic valve, above the aortic valve, or below the aortic valve? It's actually below the aortic valve. So here's, you can see the aortic valve here, and then we can see the turbulent flow here. So that starts right below the aortic valve. Outflow tract view is a little bit harder to tell, but it does look like it's starting there, right below the aortic valve. Easiest to tell here, right? So we have a flow disturbance that's starting below the aortic valve. So what do we think is going on here? So there's, yeah, so there's stenosis right below the aortic valve, but what could be causing it? So what's the most common cause of stenosis? Yeah, so hypertrophic obstructive cardiomyopathy. Is that what this patient has? How do you know?
It's not hypertrophy.
Yeah, it's not hypertrophy, right? I mean, you're looking at, here's the interventricular septum. It's not really thickened. It's not really thickened, so it's not the septum that's causing obstruction here below the aortic valve. So in that case, if it's not the septum, what could it be? Yeah, so a rare cause of subaortic stenosis is a subvalvular membrane. And you can barely see it, right? There's this thin little dark area that's going across here, right? You can barely make that out. So subvalvular membrane, so this is an unusual cause of stenosis, and that occurs right below the aortic valve in the same location as you would have obstructive, hypertrophic obstructive cardiomyopathy. But of course, we don't see hypertrophy of the outflow tract here. Okay. Now, what kind of view is this? Yeah, so it's a left ventricular outflow, again, also called three-chamber view. So this chamber is left atrium, left ventricle, aorta. What's wrong here? Is there a flow disturbance?
Yes.
Yes, where? At the aortic valve, above the aortic valve, or below the aortic valve? So again, it starts below the aortic valve, so you can see the turbulent jet that starts here below the aortic valve, okay? So in this case, what's the cause? So this is hypertrophic obstructive cardiomyopathy. How do you know? Now the septum is hypertrophic, right? So you can see all this hypertrophy in the septum extending to the outflow. There's also a bonus finding here. What's the bonus finding?
Systolic anterior motion.
So how is that manifested? Mitral regurg, yeah. So you can see here that there's a little flash of mitral regurgitation, right? That little flow disturbance there going back into the left atrium. So that little flash of mitral regurg, so mitral regurg can be associated with hypertrophic obstructive cardiomyopathy. And as you mentioned, that's because of SAM, systolic anterior motion of the anterior leaflet of the mitral valve. So it's hard to demonstrate, but the anterior leaflet can move into the outflow tract, and that during systole, and that causes that little bit of mitral regurgitation. So you can see some mitral regurgitation associated with HOCM. Okay? So subvalvular aortic stenosis, we can see that with a membrane. With the membrane, that's really rare. Most commonly, it's from hypertrophic cardiomyopathy. Right? So the subvalvular membrane, you can see it here on the angio. There it is. Okay? So the jet can cause damage to the aortic valve and can also result in aortic insufficiency in addition to aortic valvular stenosis. Right? So this was the case that we saw, that very thin, subtle subvalvular membrane over here. But you suspected because the flow disturbance begins below the aortic valve, and there's no hypertrophy of the ventricle to explain that. Here's a CT which illustrates it nicely. So there's the aortic valve. Here's the subvalvular membrane right below the aortic valve. So there it is there. And here's kind of a volume rendered view to show it to you. Right? And now we'll cause stenosis then right below the aortic valve, the subvalvular membrane. Okay? With hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy, there's obstruction of the outflow tract here from hypertrophy of the septum along the outflow tract. And then, as we said, you might get a little bit of mitral regurgitation from systolic anterior motion of the anterior leaflet of the mitral valve. Okay? Okay, so what are we looking at here? We have some images from a CT scan. What's abnormal?
Yes. Stenosis above the valve.
Yeah, so here there's narrowing or stenosis of the aorta above the aortic valve. Here's the aortic valve. Here are the sinuses of Valsalva. Here's a coronary artery here. Okay, looks like the right coronary artery. And then here we have narrowing right there. Okay, so supravalvular aortic stenosis can also occur. We mentioned earlier that's associated with what syndrome? Right, so that can be associated with Williams syndrome, or it may occur in isolated. This case would happen to be an isolated case. Okay, so supravalvular aortic stenosis. Again, this is pretty unusual, pretty rare. Right? So, but it can be part of Williams syndrome. Williams syndrome, also called infantile hypercalcemia syndrome. These patients can have hypercalcemia, often faces mental retardation, stenosis in branch vessels of the pulmonary arteries. So in addition to involving the aorta, they can also have stenosis in other vessels like pulmonary arteries and renal arteries. So here there's some stenosis of the pulmonary arteries in addition to the supravalvular aortic stenosis. And because of that stenosis, they can also develop dilatation of the sinuses of Valsalva and also the coronary arteries because of the high pressures in those regions. Okay, so that's Williams syndrome. But this was the case, supravalvular aortic stenosis. So stenosis above the aortic valve. What's abnormal on the chest radiograph here?
Ascending aorta is
Okay, so the ascending aorta is what?
prominent, shifted to the right.
Yeah, tortuous or dilated. What about the descending aorta? You like that?
Mm.
So that's also tortuous and dilated, right? So we have, looks like dilatation or tortuosity of both the ascending and descending thoracic aorta. What about the heart itself? Yeah, the LV looks like the left ventricle here. Looks like the left ventricle is enlarged, right? So what valvular lesion would give you tortuosity or dilatation of the ascending and descending aorta and dilatation of the left ventricle? Aortic insufficiency, yes, aortic insufficiency can do that, okay? So what are causes of aortic insufficiency? Yeah, so one cause is anything that gives you an aneurysm of the ascending aorta, right? So whenever you get dilatation of the ascending aorta, you can get dilatation of the aortic annulus, so that can cause aortic insufficiency. What else? Sinus of Valsalva aneurysm, right? But that's kind of the idea, right? The dilatation of the root of the aorta there. So Marfan's, right? Marfan's can do it. Bicuspid aortic valve. In addition to aortic stenosis, bicuspid aortic valve, those patients can also have aortic insufficiency. Other things like endocarditis, those are some rarer causes. Sometimes rheumatic heart disease, even though that it usually causes aortic stenosis, might also result in aortic insufficiency. So here's a CT scan, and here we're looking at the aortic valve. Anything wrong with the aortic valve in this case? What? So how do you know? Because I'm telling you, this is the aortic valve at diastole, right? So at diastole, the aortic valve should be completely closed. So how can we make the diagnosis of aortic insufficiency with CT? When the aorta should be completely closed at diastole, you can see there's still a small opening here in the aortic valve. Right? So in your diastolic images, the aortic valve should be completely closed. So this patient must have some aortic insufficiency. Right? So you can make the diagnosis of aortic insufficiency on CT, provided you're looking at the aortic valve in the proper phase. The normal aortic valve in diastole should be completely closed. So in systole, it should open up very nicely, but in diastole, it should be completely closed. All right? If there remains a hole there, an opening, then you have aortic insufficiency. Okay? So this patient has some aortic insufficiency. Left ventricle is also dilated, which you would expect in somebody with aortic insufficiency. Okay? And then here on this coronal view, you can see that the aortic valve does not close completely. Those leaflets do not come completely together. Okay? Now, aortic insufficiency can also give you dilatation of the ascending aorta, right, as we see here. So that can occur with aortic insufficiency and descending aorta also with aortic insufficiency. What's wrong with this person?
Sinuses of Valsalva.
Yeah, so this person has dilated sinuses of Valsalva, all three, right? All three sinuses of Valsalva are dilated here. And somebody mentioned the sign. What is this sign? Tulip bulb sign, right? So that's some dilatation of the aortic root and sinuses of Valsalva, right? So this is associated with Marfan syndrome, right? And these patients also can have aortic valve insufficiency. Anything that dilates the aortic root can lead to dilatation of the aortic annulus and can be associated with aortic insufficiency. Here we see it on the MR. So here's your tulip bulb sign, and then here on the MR, we have this flow disturbance going back into the left ventricle from aortic valvular regurgitation from aortic insufficiency. Okay? So causes: bicuspid aortic valve, rheumatic heart disease, endocarditis, trauma, diseases of the aorta, anything that dilates the aorta can cause aortic insufficiency. Okay? Aortic root dilatation is probably the most common cause of aortic insufficiency, and then we have, bicuspid valve as a single cause, and then there are other miscellaneous causes. So with aortic insufficiency, we will get dilatation or tortuosity of the ascending aorta, and you'll also get dilatation of the left ventricle. Okay? So dilated ascending and descending thoracic aorta, big left ventricle, so we can see this with aortic valve insufficiency. Systemic hypertension can also give you dilatation or tortuosity of the ascending and descending thoracic aorta. Usually the left ventricle, although it can be thickened, doesn't dilate until later on. So we can't tell hypertrophy on the plain film, right? We only look at the size of the left ventricle. But with the tortuosity of the ascending and descending aorta, you can see this with systemic hypertension, although usually the left ventricle doesn't dilate until later on in the course of disease. Okay? So this patient has some hypertrophy of the left ventricle from systemic hypertension, but the chamber itself doesn't dilate until you get decompensation. What are we looking at here? So what kind of view is this? Yeah, what kind of study?
CT.
Yeah, so this is a retrospectively gated cardiac CT. So this chamber here is left atrium, left ventricle, this guy here, and this guy here. Okay, so what's wrong with the aortic valve? Yeah, so there's this filling defect that's sitting on top of the aortic valve. So two main differentials, right? If you have a filling defect like that sitting on the, actually there are three, but we'll start with the two most common ones. So the two most common causes of this would be what? Somebody mentioned vegetations. So what question would you ask? Okay, so is there any history that would go with that? Is there any signs of bacteremia? Right? Is the patient septic? Any signs of infection, septic emboli, et cetera, right? So vegetation is one thing in the differential. What else is in the differential? Thrombus, right. So thrombus is also in the differential, so those patients should not have any evidence of infection. Okay, there's a third thing that's also in the differential that is much rarer than those first two. So for those of you studying for the boards, papillary fibroelastoma, right. So papillary fibroelastoma is a growth that can occur on the aortic valve. Those patients are usually completely asymptomatic. Okay. So this, of course, would turn out to be a vegetation on the aortic valve. Okay. What's wrong here? What do we call this? So this is a quadricuspid aortic valve. So this person has four cusps. Again, a rare morphologic abnormality of the aortic valve, a quadricuspid aortic valve. Okay. So what's going to be the problem of the aortic valve in patients with quadricuspid aortic valve? What kind of problem will they have? It's actually illustrated here nicely. Regurg, right. These patients will have aortic valve regurg, and you can see that the aortic valve does not close all the way, right? What congenital heart disease is quadricuspid aortic valve associated with? Truncus arteriosus, yes. So it can occur isolated, right? But as far as congenital heart diseases, this can be associated with truncus arteriosus, quadricuspid aortic valve. Okay, so four cusps, very rare, 1 in 8,000. They can have aortic regurg and can be associated with truncus arteriosus. Okay. So what kind of views do we have here? One on the right, of course, is easy. I've shown you a bunch of those already. One on the left is a short axis view, correct? This one is. Yeah, so that's a three-chamber or left ventricular, we call left ventricular outflow tract. So what's wrong with this person?
Mitral.
Yeah. So you're thinking about, so which valve is this, right? That's the question. Which valve is this? That's the mitral valve, right? So what's wrong with the mitral valve? It's calcified and it's thickened, right? Calcified and thickened. And then here, we can also see that it's not quite opening all the way. What chamber is dilated?
Left atrium.
Left atrium. So what does this patient have? Mitral stenosis. What's the etiology going to be then? Rheumatic heart disease, right. Now there's a particular shape of this mitral valve that we've talked about or mentioned, the hockey stick deformity, right. So the hockey stick deformity where it looks like a hockey stick, so that is associated with rheumatic heart disease and mitral valve stenosis. So it's a patient with mitral valve stenosis from rheumatic heart disease. Okay. The findings on the plain film associated with rheumatic heart disease or mitral stenosis, what will we see? Yes, dilatation of the left atrial appendage, that is this bump over here. 3 bumps, the aorta, this one is main pulmonary artery, and this one is the left atrial appendage, right below the left main bronchus. So if there's any bump there, right, that's enlargement of the left atrial appendage. You can also tell in the lateral view, there's some bulging in the region of left atrium. So left atrial enlargement, especially enlargement of the left atrial appendage, okay. Other signs, you might have pulmonary venous congestion, okay. Other signs of enlargement, what's another sign of enlargement of the left atrium? Double density, right, behind the right atrium. If there's a density behind the right atrium, that's a double density sign. That's an enlargement of the left atrium. So things that can cause enlargement of the left atrium, of course, mitral stenosis, rheumatic heart disease, atrial fibrillation can also give you left atrial enlargement. So you might come across cases of that also. But pulmonary venous hypertension, that is associated with mitral valve stenosis. So with mitral stenosis, this is usually secondary to rheumatic heart disease. So that causes scarring and fusion of the leaflets. Early on, these patients develop mitral regurgitation, but as it scars down, then they form mitral stenosis. On the plain film, the differential would be left atrial myxoma, because that can also give you stenosis of the mitral valve, but that's really rare. Over 99% of the time, it's going to be heart disease from mitral stenosis from rheumatic heart disease. So from obstruction of the mitral valve, they develop left atrial hypertension, which backs up into the pulmonary venous circulation. They develop pulmonary venous hypertension. They can develop pulmonary edema. And then secondarily, that can also go back into the pulmonary arterial circulation. They can develop pulmonary artery hypertension. That can cause failure of the right ventricle. They can develop pulmonary insufficiency, tricuspid regurgitation. So signs, the clinical symptoms, shortness of breath, palpitations, easy fatigue, hemoptysis can all be signs of rheumatic heart disease. Early on, left atrial enlargement. As it advances, they'll develop more enlargement of the left atrium, but when they develop pulmonary artery hypertension, then we start to get right ventricular enlargement. Pulmonary venous hypertension, cephalization, interstitial edema, signs of pulmonary artery hypertension, big pulmonary arteries. Calcification of the mitral valve, it's pretty hard to see that on the plain film. It's not as common as aortic valve calcification as we see in cases of aortic valvular stenosis, okay? So enlargement of the left atrial appendage, enlargement of the left atrium. So we can see that double density on the right from the left atrial enlargement. Later on, they can develop enlargement of the pulmonary arteries as they develop pulmonary artery hypertension. This patient also has a nice double density here from left atrial enlargement. Okay. This one has some calcification here of the mitral valve. This is pretty unusual to actually see that on the plain film. You can see the left atrial enlargement, the bowing on the esophageal column of barium from left atrial enlargement. Okay. And then calcification of the mitral valve. So we can see that on the CT. And thickening of the mitral valve. You can also see that on CT, thickening of the mitral valve in cases of mitral stenosis. I think what we need to do is, we'll finish with this case. So what is calcified here? So that's calcification of the left atrial wall, right? So what's the significance of calcification of the left atrial wall? What is that associated with? Yeah, these patients will have atrial fibrillation, and it's almost always rheumatic heart disease, right? So from inflammation of the atrium, these patients develop calcification, and these patients almost always have atrial fibrillation. The significance of this is that these patients can also develop, of course, clots within the left atrium, and also there's a surgical risk if they operate to fix the mitral valve. Bleeding can be difficult to control because the left atrial wall will be calcified and very stiff. So calcification of the left atrial wall is very strongly associated with rheumatic heart disease. Let's do this case because this one's interesting too. So first of all, when we look at the moguls there in the mediastinum, what's enlarged? Yeah, the main pulmonary artery is big. What do you think of the right pulmonary artery? Also enlarged. So this patient has pulmonary hypertension, right? And then what chamber is big here? Left atrial appendage, right? Left atrium. So if the left atrium is big and the patient has pulmonary hypertension, There you really have to put rheumatic heart disease high up on the list, right? Now there's another finding when we look at the lungs. What do we see? Yeah, there's these calcifications here in the lungs, these round calcifications, right? So how do we put this together with the heart disease? What's going on? Well, it's not embolization, no. So these are pulmonary ossifications associated with rheumatic heart disease. So this is from pulmonary hemosiderosis. All right. So these are areas from the pulmonary venous hypertension. These patients can develop small areas of hemorrhage in the lung that go on to ossify. So they develop really pulmonary ossifications. So this is a late manifestation of rheumatic heart disease, is these pulmonary ossifications. So this can also be a manifestation of rheumatic heart disease, pulmonary ossifications. Okay, what's the finding on the chest radiograph? What's abnormal? Yeah, so there's a right upper lobe consolidation. So the question is, what valve lesion can look like this? So what valvular lesion can be associated with the right upper lobe consolidation?
Oh, mitral regurg.
Yeah, but you have to tell a story, right? So what's
Right.
the story?
For mitral regurg, if it's unilateral, we spoke about this, right? Unilateral pulmonary edema can be seen in the setting of like a papillary muscle rupture.
Yeah, so it has to be acute mitral regurgitation, especially in the setting of myocardial infarction and papillary muscle rupture. What happens there is the acute mitral regurg isn't well tolerated. That can lead to pulmonary edema, but the jet can be directed towards the right upper lobe pulmonary vein. So hence the consolidations can be worse on the right side, but especially in the right upper lobe. So right upper lobe consolidation or right-sided consolidation can be associated with acute mitral regurgitation from papillary muscle rupture. So the causes of mitral insufficiency, acutely it can be from rupture of the papillary muscle, rupture of the chordae tendineae, that can occur from infection or trauma. Rupture of the papillary muscle, pretty rare for it to occur from trauma, mostly it's secondary to ischemia. And then there are causes of chronic mitral regurg. Anything that dilates the mitral valve annulus can also result in mitral valve regurgitation, but with rheumatic fever, the early lesion is mitral regurg, and then later on you get scarring, and that becomes mitral stenosis. And then some other things are also listed there. Now, with mitral regurg, the appearance on the chest radiograph and the pathophysiology depends on the status of the left ventricular myocardium and whether it is acute or chronic. So if you have acute mitral regurgitation with normal myocardium, then you have a well-functioning left ventricle, so there's going to be a large regurgitant volume that's not going to be well handled, and so that leads to pulmonary edema. Chronic mitral regurg with normal myocardium, there again you have a pretty decent cardiac output from the left ventricle, but this results in dilatation of the left atrium. This gives you very large or giant left atrium. And then mitral regurg secondary to left ventricular failure. You might see that with papillary muscle dysfunction. So here, when you have left ventricular failure, the output of the left ventricle is not as high. So you do get some dilatation of the left atrium, but it is not as big as you get with cases of chronic mitral regurgitation. So acute mitral regurgitation, normal myocardium, or a good ejection fraction, good cardiac output, it's not well tolerated. Patient goes into pulmonary edema. Okay? And especially with papillary muscle rupture, if it's right side, the right side tends to be worse than, or can be worse than the left side. So rupture of the papillary muscle, so we talked about this already, that right upper lobe consolidation that can be seen with that. With normal myocardium, like you might see with rheumatic heart disease, here the mitral regurg starts to dilate the left atrium, and the left atrium can get really big. You can get what's called a giant left atrium in this condition. So the size of the left atrium is related to the degree of mitral regurgitation, as opposed to mitral stenosis. The severity of mitral stenosis does not really, or the size of the left atrium is not as closely related to the severity of mitral stenosis as it is related to the severity of mitral regurg. Okay. So rheumatic heart disease, you get a really big left atrium because of the mitral regurgitation. So big heart, big left atrial appendage, big, so over here, we have a big double density down here from, actually I think it's up here, from the mitral, from enlargement of the left atrium. And then when we have left ventricular failure, so here you can have papillary muscle dysfunction. Left atrium does not quite get as big because that regurgitant volume is not as much because the left ventricular function is impaired. But you will see pulmonary venous hypertension, cephalization. You may get pulmonary edema because of the left ventricular failure. So some enlargement of the left ventricle, some pulmonary edema, but the left atrium is not quite as big as it gets with chronic mitral regurgitation with a well-functioning left ventricle. Okay, what's wrong with the X-ray here? So what's abnormal? So what chamber's enlarged?
Right atrium.
Yeah, so the right atrium is enlarged. So what valvular lesion might give you this kind of enlargement of the right atrium? Well, which one is more likely?
Regurgitation.
Yeah, tricuspid regurg is more likely than tricuspid stenosis, and that can give you not only a big right atrium, but also a big right ventricle. So here we have a young person, 23-year-old, with a big right atrium and a big right ventricle. You also have reflux of contrast there into a dilated IVC and hepatic veins. So what could cause this?
Like the cuspid valve, like endocarditis.
Yeah, so especially in a young person, endocarditis, IV drug use, right? So endocarditis can affect the tricuspid valve, give you tremendous tricuspid regurg, destruction of the tricuspid valve, and you'll get large right-sided chambers like this. And also you can see the reflux of contrast there to the dilated IVC and the hepatic veins, okay? So there are causes of tricuspid regurg, right ventricular failure will cause dilatation of the annulus, so that can occur from pulmonary hypertension. So almost all patients with pulmonary hypertension do develop tricuspid regurgitation or significant tricuspid regurg. So IVDA, endocarditis, trauma is rare, and then some other things here. Congenital causes, Epstein's, AV canal defects, pulmonary hypertension in newborns, although those are unusual, but Epstein's especially. So why isn't this Epstein's? So what do you look at? What do you look at to make the diagnosis of Epstein's?
It's like ventricular displacement of it's a particular part of the tricuspid.
Which one?
It's like the septal.
The septal leaflet. So you look at the insertion of the septal leaflet. So with Epstein's anomaly, that's going to be displaced towards the apex of the left of the right ventricle. Okay. So that's what you see with Epstein's. That leads to dysfunction of the tricuspid valve, and you'll get dilatation of the right atrium and the right ventricle in that condition. So you look at the location of the septal leaflet of the tricuspid valve to make the diagnosis of Epstein's. Without pulmonary artery hypertension, tricuspid regurg can be well tolerated before you get right ventricular failure. With pulmonary hypertension, though, tricuspid regurg can lead to systemic venous congestion and pulmonary oligemia. Actually, the blood flow to the lungs can be decreased. So if there's signs of pulmonary venous congestion, that might improve, but you'll get ascites and peripheral edema in that case. If there's a pain foraminal valley, the elevation of the pressures in the right atrium can lead to right to left shunting through a pain foraminal valley. So dilated right atrium and right ventricle is what we can see with tricuspid insufficiency. So the findings here, on the left side, what's abnormal? Yeah, so the size of the right atrium is large, right? So the right atrium and the right ventricle are big, right? And the arrow is pointing to what here on this side? Well, some abnormality in the liver, right? So what would give you this combination of some abnormality in the liver with right-sided cardiac dysfunction?
Carcinoid metastasis.
Yeah, so carcinoid metastases. So carcinoid metastases to the liver So the metabolites from the tumor can be damaging to the right-sided heart valves, but the liver does, the liver can degrade those metabolites, but once you get metastases in the liver, then it bypasses the liver and has direct access to the IVC in the right-sided, the right heart. And so that can lead to damage to the right-sided heart valves, like the tricuspid valve and the pulmonic valve. So we can get that carcinoid heart disease. So the metabolites damage the valve, fibrous plaques form on the valves on the right side. Adhesions between the tricuspid valve and the right ventricle cause tricuspid regurg. Plaques on the pulmonic valve cause pulmonic stenosis. So you can have a combination of tricuspid regurg and pulmonic stenosis. So these plaques that form on the pulmonic valve can cause pulmonic valvular stenosis. The plaques here that form on the tricuspid valve cause adhesions, and so then you can develop tricuspid regurg. Now, these noxious metabolites, they are metabolized in the lung, so it doesn't affect the left-sided valve. So that's why when you have carcinoid heart disease and mets to the liver, you can get this effect on the right-sided heart valves. So with pulmonic stenosis, you can have poststenotic dilatation of the pulmonary artery. With tricuspid regurg, you can get dilatation of the IVC. So that combination of tricuspid regurg and pulmonic stenosis, that can be seen with carcinoid heart disease. Okay. Tricuspid stenosis is more unusual. It can occur with rheumatic heart disease, but usually other heart valves are involved at that point. They usually have mitral valve disease, and congenital is pretty rare. Right atrial myxoma also pretty rare. And with carcinoid syndrome, tricuspid regurg is more common than tricuspid stenosis. So tricuspid stenosis is not a common abnormality, but that can also give you dilatation of the right atrium when you have stenosis of the tricuspid valve. Okay, so what's wrong with this chest radiograph?
Enlarged pulmonary artery.
Yeah, so we have enlargement of, so this bump over here represents what? Main pulmonary artery. So you have aorta, main pulmonary artery, left atrial appendage. Enlargement of the main pulmonary artery, and this guy over here is left pulmonary artery. So the main and the left pulmonary arteries are enlarged. What about the right pulmonary artery? Looks normal. So what does that mean? Pulmonic valvular stenosis, right. So if the right pulmonary artery was big, you'd be thinking about pulmonary hypertension. But with enlargement of the main and left pulmonary artery with enormous size right pulmonary artery, you think of pulmonary valvular stenosis. It's usually congenital, but like we've said, carcinoid might cause it, can also occur with rheumatic heart disease. So you will have this configuration of enlargement of the main and the left pulmonary artery with that. So what happens is that jet extends from the main pulmonary artery into the left pulmonary artery. The left pulmonary artery is continuous with the main pulmonary artery, so you get poststenotic dilatation there. The right pulmonary artery comes off at an angle, so the right pulmonary artery does not get enlarged. So that's why you get that configuration with pulmonic valvular stenosis. So here you have stenosis and poststenotic dilatation here in the main pulmonary artery extending into the left pulmonary artery in this case. Okay. So again, pulmonic valvular stenosis, dilatation of the main pulmonary artery. This can be treated with congenital pulmonic stenosis, can be treated with valvuloplasty, so put a balloon in there and dilate up that area of pulmonic valvular stenosis. Pulmonary insufficiency, this is most commonly caused by pulmonary hypertension, anything that elevates the right ventricular pressures. The tricuspid valve so pulmonary insufficiency, the pulmonic valve does not handle elevation of pulmonary artery pressures very well. So when the pulmonary artery pressure is elevated, it's common to get pulmonary insufficiency. There are some other causes also that I've listed here that can also give you pulmonary insufficiency, but pulmonary hypertension is the most common cause. So what you tend to see is what you see with pulmonary hypertension. So big central pulmonary arteries here, enlargement here along the outflow tract of the right ventricle, exactly what you would, these are the manifestations of pulmonary hypertension, which tends to be the main cause of pulmonary regurg. Pulmonary regurg can also, in and of itself, result in enlargement of the central pulmonary arteries, even without pulmonary hypertension. So if you have severe pulmonary regurg, let's say there's something wrong with the pulmonic valve there, you can get enlargement of the central pulmonary arteries without pulmonary hypertension. Okay. What's wrong here? This person has a systolic heart murmur.
Something quadru,
Yeah, so it's a quadricuspid what?
aortic valve.
That's not, well, is that the aortic valve?
Or no, the ascending aorta.
Is that the ascending aorta?
No, sorry, the pulmonary, sorry.
That's the pulmonic valve, right? That's a quadricuspid pulmonic valve, right? We talked about quadricuspid aortic valve, so quadricuspid pulmonic valve can also occur. It's a quadricuspid pulmonic valve. It tends to be associated with aortic valvular abnormalities too. So normal septation, you get tricuspid pulmonic valve, tricuspid aortic valve with abnormal septation. You can have a quadricuspid pulmonic valve with a bicuspid aortic valve. So it's associated with aortic valve anomalies. It's obviously very rare, so they can have pulmonary regurgitation or stenosis. Now, let's talk about MR evaluation of valvular diseases. All right. By the way, what kind of view is this?
LVOT.
Yeah, it's an LVOT or three-chamber view, and it's illustrating what?
Both aortic regurg and stenosis.
Yeah, you have both aortic regurgitation, regurg down here, coming down, hitting the anterior loops of the mitral valve, and stenosis as it extends up above the aortic valve. Okay. CT gives you good spatial resolution. MRI is very good for temporal resolution. So MRI is good for looking at cardiac function and especially for looking at valves, for looking at these valvular abnormalities. So we've talked about how to get the left ventricular outflow tract view from your short axis view. If you want to look at the aortic valve, you want to look at it en face. So what you want to do is prescribe a view going right through the aortic valve, and you can get that from your left ventricular outflow tract view. And actually, the best way to do it is to have this view and a nice coronal view going through the aorta and then line up the plane in both views to go through the aortic valve. And you can get a good view of the aortic valve, and that tells you the morphology of the valve. And you have to look at the valve when it's open, though, to be able to tell the morphology of the valve. And then we've talked about phase contrast MR, so we can look at the amount of flow that also goes through the ascending aorta, so we can measure that throughout the cardiac cycle. Okay. The cross-sectional area times the average velocity gives you the flow rate, so we can calculate the flow rates through either the aorta or the pulmonary artery with phase contrast MR. If you have aortic regurgitation, you see it changes color. In this case, it's white when it's going up, black when it's going down when there's regurgitation. So you can measure that regurgitant flow, and you can assess the severity of aortic regurgitation with phase contrast MR. And then with 4D flow, you acquire a whole volume, and then you can go back and measure anywhere you want to determine, what the flow is through the various vessels that you've incorporated here in your 3D volume. Okay. So this is an example of aortic stenosis. You can see it's not opening all the way, and then here we have phase contrast showing the flow there through that area of aortic stenosis. So we can take velocity measurements just above the aortic valve through the jet. We can also measure the area of the aortic valve. What's the equation for calculating the pressure gradient? So this has come up on exams. So what is that equation? The modified Bernoulli equation, what is it? The pressure, that peak gradient equals what?
4V squared.
4V squared. So the velocity has to be expressed in what units?
Meters per second.
No.
Meters per second?
Meters per second. So you have to express the velocity in meters per second. The gradient comes out in what units?
Why does it say centimeters per second on the graph?
Well, the graph gives you centimeters per second. You have to convert that to meters in your equation, right? I mean, if this were meters, it would like be way down here, right? It would be a very, very short graph. Right? So the units come out in millimeters of mercury, right? So the modified Bernoulli equation for V squared, in this case, the peak velocity was 3.5 meters per second. Plug that into your equation, and you get the peak pressure gradient in millimeters of mercury, right? The modified Bernoulli equation. So using this by measuring the peak velocity, we can also calculate the peak pressure gradient there above between the left ventricle and the ascending aorta. You can also directly measure the opening of the aortic valve itself. So when the aortic valve opens maximally, we can measure the area for that, and that does correlate with the degree of aortic stenosis. If it's less than 1 centimeter squared, you have pretty severe aortic stenosis, or pretty significant aortic stenosis at that point. That's called planimetry. So we can also do that. So here's an example. So you can see the aortic valve is not opening all the way, and we can measure that to get an idea of how severe the aortic stenosis is. You don't have to worry about the numbers here, but there are these tables that we can use for MRI. So depending on the peak pressure gradient, the peak velocity, the peak pressure gradient, the aortic valve area, gives us an idea whether it's mild, moderate, severe, or very severe in terms of aortic stenosis. So we can use MRI to grade the severity of aortic stenosis. And then we can use that. There are also the indications for, when does the patient need valve replacement. Again, I don't need you don't need to memorize this, but we can use this to guide therapy also with MRI. Okay. Now the other thing, when you're looking at valves with MRI, we talked about these balanced gradient echo sequences, SSFP, but there are also these non-balanced sequences that you can use, conventional Cine gradient echo sequences. These have somewhat longer TRs and TEs. But what this allows you to do is, when you're dealing with the valves, you can see the valve itself, that contrast between the valve and the blood flow, a little bit easier on these sequences. So with true FISP or SSFP versus SPGR, you can see the aortic valve a little bit better. So if you're having trouble, I found the SSFPs though pretty good. They're usually good enough. But if you're having trouble, you can't switch to these sequences if you specifically want to look at the aortic valve. More examples. Here's a bicuspid valve. You can see the morphology is a little bit better demonstrated here on the spoiled grass sequence compared to the balanced gradient echo sequence. Okay. What's going on here? What do we got?
It's showing both stenosis and regurg.
Yeah, so you can see here on FOSS that it looks like there is stenosis, and then here on this coronal view, you can see there is also some aortic regurg. What's wrong with the aortic valve? Yeah, it's a bicuspid aortic valve. What's the black stuff? Those are calcifications. Yeah, those are calcifications on the aortic valve. Right? So here's a patient who has very dark stuff here on the aortic valve. So when we see something like this, what could cause this? What gives you this appearance when you have all this signal dropout along the aortic valve? What could do that?
Mechanical valve.
Sure. I mean, the obvious one is that there's a mechanical valve replacement, right? So that's one. What else? Calcifications, right? That could do it. What else? What? Vegetation, right? This was a case of vegetations, right? So vegetations can also do this, okay? So that dark signal around the valve, vegetations can cause loss of signal like that, or I guess from turbulence and stuff around the valve. Okay? So here again, we have post-stenotic dilatation, and you can see the jet from aortic valvular stenosis here in this case. And then when we look at the aortic valve on FOSS, what do we discover?
Bicuspid.
Yeah, it's another example of a bicuspid aortic valve. Okay, you have to look at it when it's open. When it's closed, you can't really tell. When it's open is when you can tell that that's a bicuspid aortic valve. What's wrong here? There's aortic regurg. Why? So we can see the aortic regurg, the jet's coming back into the left ventricle. Why does this patient have aortic regurg?
There's dilatation of the proximal ascending.
There's marked dilatation here of the sinuses of Valsalva, right? So what does this person have? Marfan. So this is a nice, what sign is this? Tulip bulb sign. It's a nice tulip bulb sign. It's a patient with Marfan. So dilatation of the aortic root and sinuses of Valsalva can also cause aortic valvular regurgitation, as we see here. And again, you know, there are these tables that we can use to quantify the extent of aortic regurg, whether it's mild, moderate, or severe, and then whether the patient needs valve replacement. Right? So there are criteria that can be used based on your findings on MR, where, you know, when the patient needs valve replacement. Okay? So what kind of views do we have here? This view is two-chamber view, right? That's left atrium, left ventricle. This guy over here is that's left atrial appendage. And this one, of course, is three-chamber or left ventricular outflow tract view. So what's wrong with this patient?
So mitral regurg.
Yeah, this patient has mitral valve regurgitation, right? So we can see that this patient has mitral valve regurgitation. Okay. So how can you assess the severity of mitral valve regurg with MR? What can you do? So we want to know, we have this patient with mitral regurg, easily demonstrated. How bad is it? How do we figure that out with MR? That doesn't work, actually, because it's not like the aortic valve, where the aortic valve is, you know, or the ascending aorta is nice and round, and everything kind of goes through there. So here, the mitral valve is more spread out. So actually trying to measure the jet or the flow actually directly through the mitral valve does not work well. So you can't do that.
The volumes.
What do you do?
Use the volumes.
So what do you do? What do you calculate?
End diastolic minus end systolic.
What does that tell you?
I guess divided by end diastolic. It tells you the regurgitant volume.
Well, but to calculate, so you want to calculate the volume going through here, right? So when the left ventricle contracts, it can only go in two places, right? What are those two places?
Aorta back into the atrium.
Yeah, it can either go up the aorta or back through the left atrium, right? Now, we cannot directly calculate the amount that goes back through the left atrium, right? But can we calculate the stroke volume of the left ventricle?
Mm-hmm.
Yes, and you just told me how, right? What is that?
End diastolic minus end systolic.
Yeah, the end diastolic volume minus the end systolic volume is the stroke volume of the left ventricle. So that's how much leaves the left ventricle each time it contracts, right? Can we measure the amount that goes through the aorta? Yes or no?
Yes.
Yeah, that's pretty easy, right? Phase contrast, we'll measure the amount that goes through the aorta. Once we have those two, right, if you subtract the amount that goes through the aorta from the stroke volume, that's got to be the amount that went backwards into the left atrium. And that's how we do it. It's an indirect measurement. So with MR, if you want to calculate the severity of mitral valve regurgitation, it's really an indirect measurement. So what we do is we measure the flow through the ascending aorta, and we measure the stroke volume. And the stroke volume you get from, you calculate your end diastolic volume and your end systolic volume, so that's pretty easy too. We do that off of our short axis views, right? So on our short axis views at end diastole and end systole, we calculate the volume of the ventricle. The difference is your stroke volume. Stroke volume minus the aortic flow, that's how much went through the mitral valve. So that's how we calculate the mitral valve regurg. And in this particular example, we got 51 milliliters, and the regurgitant fraction here was 40%, pretty significant. Okay? So, what's wrong with this person?
Again, there's mitral regurg.
Yeah, again, this time a lot smaller, right? So there's a little bit of mitral regurg. What's the cause? What's causing the mitral regurg in this person?
Looks like there's anterior.
It dilated cardiomyopathy.
Yeah.
Maybe slightly dilated.
No, it's, I mean, it's a little bit, but it's not really that big. So look at,
Hypertrophy.
look at the position of the mitral valves here, right at the end. See how they're bowing back a little bit? You see that?
Mitral valve collapse?
Yeah, mitral valve prolapse. It's mild mitral valve prolapse. So mitral valve prolapse can also cause usually mild mitral regurg. Okay? And again, with mitral regurg, based on what we calculate with MR, we can figure out whether it's mild, moderate, or severe from the regurgitant fraction or the regurgitant volume. Again, I don't need you to memorize the tables, but we can use this to figure out, when the patient needs valve replacement. So if the regurgitant fraction greater than 50% or the volume greater than 60 milliliters, then the patient will need valve replacement if they're symptomatic. Okay? So what kind of view is this?
It's a 4-chamber.
That's a 4-chamber view. What chamber's dilated?
Left atrium.
Left atrium, right? What's wrong?
Mitral stenosis.
Yeah, so you can see the mitral valve is not opening all the way. So there is some mitral stenosis. You can see a little bit of the jet. Also in this case, there's another problem with the mitral valve. What is it? Prolapse again, right? You can see the prolapse. So there's also a little bit of mitral valve prolapse. But the main problem, there's not much regurg. We don't see regurg. So the problem here is mitral stenosis. Okay? What's wrong here?
Zero.
Yeah, so this is pulmonic stenosis. So first of all, notice the main and the left pulmonary artery are bigger than the right. There's turbulence in the main and the left pulmonary artery, not in the right pulmonary artery. There's poststenotic dilatation here. You can see the pulmonic valve. You can see the jet coming right off the pulmonic valve. So this is pulmonic valvular stenosis. Can we assess the severity of the stenosis? How would we do that? How do you assess the severity of?
Same way as we do aortic.
So what do you do?
Phase contrast.
Yeah, with phase contrast, what do you measure? So you've learned to say phase contrast, but you're not telling me what you're going to measure. What are you going to measure?
You're measuring the velocity going through the
You're going to measure the peak velocity where?
at the center of the.
Anybody?
Just,
Uh,
just
Well, just above the aortic valve where the jet is. Right? So you're going to measure the peak velocity in that jet. And then you're going to take that number and you're going to do what?
Meters per second.
Convert it to meters per second, plug it into the modified Bernoulli equation, and calculate your gradient. Right? So phase contrast MR in the pulmonary artery, just above the valve, get our peak velocity there, convert that to meters per second, then that tells us what the peak gradient is in millimeters of mercury. Okay? And then, again, based on the peak velocity and the pressure gradient, it also tells you, there are criteria for when, how severe is the pulmonic valvular stenosis there. Okay? This person had surgery to repair tetralogy of Fallot. Okay, so this is a sagittal view here. So this guy is what? Right ventricle. This guy is, yeah, so main pulmonary artery. So the right ventricle and the main pulmonary artery are kind of big, which is unusual, right? You wouldn't expect the pulmonary artery to be big with tetralogy of Fallot. But why does that occur after surgery for tetralogy of Fallot? Why would the pulmonary artery enlarge after surgery? Why would the right ventricle enlarge after surgery for tetralogy of Fallot?
you get regurg.
Yeah, you get tremendous pulmonic valvular regurg because the pulmonary valve is usually dysplastic. Right? So when they open up the outflow tract in that dysplastic pulmonary valve, they'll also open that up too. And so you will develop a pulmonic regurgitation. And as the patient grows older, this can become more and more severe. So why don't they fix the pulmonic valve? Why don't they put in a pulmonic valve replacement at the time that they fix the tetralogy of Fallot? Why don't they do that?
Every 10 years.
The patient would outgrow the valve, right? Remember that this is done in childhood, right? So any kind of valve replacement that you put in there, the patient's going to outgrow it. So what happens is that these patients are followed to see how severe is their pulmonic regurg, what's happening to the right ventricular function, and then when they become, young adults, if it starts to deteriorate, if there's a severe amount of pulmonic regurg, then they will require replacement of the pulmonic valve. Okay. Does this patient have any other problem?
Tricuspid regurg.
Yeah, there's tricuspid regurg here too. So here's the right ventricle on the big side, and you can see the jet and tricuspid regurg. So this patient also has some tricuspid regurgitation there. So for pulmonary regurgitation, again, with phase contrast, we can measure the forward flow, we can measure the reverse flow. And then from that, we can calculate the regurgitant flow, the regurgitant fraction, and then there are criteria for that too, to decide whether it's mild, moderate, or severe, okay? And then in a patient who's had surgery or who's had repair of tetralogy of flow, there are criteria for, what's happening to the right ventricular ejection fraction for when they might need some intervention there, okay? So if their right ventricular volume starts to dilate, if the pulmonary regurg gets bad, if the right ventricular ejection fraction goes down, then it's time to intervene in those patients who are being followed after surgery for tetralogy of flow. Okay. All right, so that is our discussion of valvular heart disease. Any questions? No? Quiz next.